And we're live in 5,
4,
3,
2, 1.
Good morning. We're coming to you this morning from the Seattle Science Foundation, and I'm Cam McDougall. This is the Fellows Question and Answer session. We have Daniel Sahlein with us this morning, from the Goodman Campbell Brain and Spine Institute, and we are delighted to have him. He's going to be speaking with us about flow diverters for more distal situations. A subject that I think hasn't been looked at enough in detail. So I'm really quite interested in hearing what he has to say about it. We often talk about cases here and go back and forth. So I think this is going to be a great session. And welcome, Daniel. We really appreciate you being here this morning. And you can go ahead and share your screen and get us started.
Great. Thank you. It's great to be here. Yeah, thank you so much for the honor of the invitation to be here with you this morning. I'm Dan Sahlein with a practice in Indianapolis, Indiana called Goodman Campbell Brain and Spine. We have a wonderful partnership with Ascension Health, and in fact, I'm the national director of the Neurointerventional Committee for Ascension Health nationally, as well as the national co-director of neuroscience research, as well as I have a role directing stroke at our local hospital, Ascension St. Vincent's, Indianapolis. So I'm going to speak to you today about flow diversion for distal medium-sized arteries. And I sort of view this in a slightly similar way as we think of MEVO and stroke, and that we have sort of distal medium vessel kind of occlusion that we talk about in stroke, but then people start to realize that there's something to be said about proximal medium vessels as well, that they have, it's sort of a different kind of understanding as large proximal vessels. And so I'll be touching on some proximal, smaller arterial aneurysms as well. So really distal and proximal medium-sized artery aneurysms today. And I'd like to start out by just like talking generally about philosophy and kind of where this talk comes from. I think that in modern biomedical science, there's been a big push towards empiricism, which I think is fantastic. I love biomedical research. I learn a tremendous amount from it. We do a lot of research ourselves, even though this is a private practice. We're very academically focused. But on the flip side, I think that when you actually go to make decisions about individual patients, one thing that you'll find quickly in your practice, particularly for those of you who are in training and haven't really had this experience exactly yet on your own, is that either a large percentage, or in some cases, perhaps even the majority of your patients, will not meet criteria for enrollment in any specific trial. And so in other words, the patient that you're looking at in your office has not necessarily been trialed. And so in these moments, which I think come up with some regularity, you're going to be forced to make a decision that is not going to be based explicitly on a trial. And what this means is that you're going to have to draw on some other body of knowledge, perhaps knowledge that is derived from a trial in some way, perhaps somewhat indirectly. But there's also something about the art of what we do, particularly, I think, in a procedural specialty, that has been pushed aside, at least to some extent, particularly when you look at talks at national meetings and these kinds of things, where there's a large focus on the big trials and reviewing the data. But I think we end up at a moment where oftentimes younger practitioners get out into the field and they're trying to decide exactly how to manage a specific patient, and they're at a little bit of a loss. That body of empiricism doesn't guide them in the way that it was sort of promised. And so I found myself, as a result, increasingly kind of tipping towards diving into the art of our craft. And you, in specific, are very fortunate that you are training in a place where you have technical masters to train with. You have extraordinary artists to train with. And so you will get this kind of exposure. in a way that a lot of places, a lot of trainees will not. But that is my sort of bent and my sort of disposition in my approach to this talk. But I'd still like to organize the cases that we'll review on the basis of some principles that I think are nevertheless tie the cases together and are learning points. And in some cases, things that we learn, in some cases, they open more questions than they answer, but things that we might all learn from by exploring. Excuse me. All right. So I'll jump into things with that. These are my disclosures. Okay. So in terms of the kind of unifying principles for the cases that we'll be reviewing and the kind of work that we do in Goodman-Campbell, the first one is that I want to kind of think about using a flow diverter as a tool that has a certain set of characteristics. And we're going to leverage these characteristics in the way that we think about treating disease. Now, some of these characteristics might traditionally be thought of as liabilities, but nevertheless, in some contexts, might actually be, beneficial. And the first case that we get into is going to specifically leverage one of the characteristics of a flow diverter. That is that they are fairly thrombogenic, particularly the first generation of the tools were thrombogenic before they started surface modification. But that is one of actually the characteristics of the tool that we're thinking about leveraging in this case. And so we're going to think a little bit outside the box, think about the set of characteristics as a series of pieces that can be leveraged, and think about those in a kind of unique way. Secondly, we're going to talk about endovascular approach or endosaccular approach in anticipation of flow diversion. That is, essentially temporizing a ruptured aneurysm in one way or another, and then bring a patient back and flow diverting. This is not a novel concept, but I think it's particularly powerful when you get to some distal aneurysms as an approach. And it's something that, at least for me, early in my career, has given me tremendous comfort, knowing that I had a flow diverter in my back pocket as something that I could follow up treatment with. We're going to be talking about flow diverting proximally to treat distally, sort of a little bit of a novel concept. We'll speak about rearranging the circle of Willis, as well as rearranging other arterial collateral circles as a really powerful mechanism of flow diverting an aneurysm, and complex aneurysm specifically. And then we're going to talk about collateral potential, not just classic PO collaterals, that is like, ACA to MCA or MCA to PCA, but other collateral systems in smaller arteries that we don't often think of or discuss, but that nevertheless, I think, make these cases safer. And also, I think, are an area that really deserves more sort of reflection and study. So with that, we'll hop into it. So firstly, we're going to talk about why flow diverters are often actually very strong choices for more distal vessels. And the first one is, I think, actually quite underrated, which is that visibility is excellent. As you get farther out in the arterial tree, you're farther away from the 5 or 6 inches of bone that you're typically shooting through in the skull base. And this means that the visibility of everything, the visibility of the aneurysm, visibility of the tool as you're deploying it, visibility of your wires and catheters is really extraordinary. And it makes cases much, much easier. The second one is that we almost always use a single device in these smaller arteries, which makes the cases fairly technically straightforward, sort of surprisingly technically straightforward in many cases, I think. I trained with Kim Nelson at NYU. I come from the Kim Nelson School of Construct Building, and yet I'm a firm believer in single device usage for the majority of these more distal cases. The smaller diameter devices open fully on initial expansion, so you have very little post-processing is needed, which I think makes the cases a little bit more, technically straightforward. Catheterization has become much easier with the introduction of the 24 wires to properly support 27 microcatheter and eliminate the ledge effect, or the 18 wire with the 21 systems that people are using now as well. And I'll also add that we will comfortably use a 2.5 millimeter stent down to an arterial diameter of approximately 1.8 millimeters. And as we'll see in the first case, we've actually used it even in sub-millimeter arterial systems. So as the first case here, a distal case, we had a 52-year-old who presents with worst headache of life, who is found to have this intraparenchymal, subarachnoid, subdural hemorrhage. And in exploring the etiology of the source of hemorrhage here on a lateral ICA injection, you'll notice if we magnify this here, we have a some pretty severe luminal irregularity right here in the M3, M4 middle cerebral artery, which is both pre-Rolandic as well as prefrontal in terms of the divisions of the middle cerebral artery that this branch is going to supply. As we get farther out into the capillary phase, notice that that branch goes straight through this area of oligemia right here in the capillary phase. So that's a way to confirm that this is actually the cause. Now, this case comes from a year or two before we started doing cone beam CT imaging with regularity. I think now what we would do is we would do Dyna CT or cone beam CT imaging, and that would really unequivocally confirm that this is the source of bleed. We'd see that this area of dissecting aneurysm is immediately adjacent to the hemorrhage. But at the time, this was a nice way of kind of elucidating this and a way that made us feel comfortable that this was actually the source of hemorrhage. So again, this was just a conventional, dual spin, 5-second acquisition 3D image. Again, we'd be doing a Dyna CT on our current Siemens Icono way of kind of thinking about this and imaging this. But notice that we have this area of vasospasm in M3, M4, this sort of ugly dissecting aneurysm. This is a patient with quite a bit of FMD in the cervical ICAs bilaterally. So we have it's about 10 millimeters in length. Notice that there's a bifurcation here, and the artery gets down to about 0.8 millimeters in size in that area of vasospasm in the M3 segment. So what were our options here? I think conventional treatment would probably be arterial sacrifice, and I think the patient would have tolerated this in this location. But conversely, sacrifice is not that easy. It's not that easy to sacrifice PL arteries. It's a very low resistance circulation, and in trying to pack coils, which is probably what we would have used, tightly enough to actually occlude the artery, you certainly run the risk of perforation. And I don't think that that's a small risk. And so for young patients, probably best to spare as much cortex as possible, even in the absence of immediate neurologic sequelae, because you have things like risk of seizures with larger areas of cortical gliosis. And so our idea was to place a flow diverter. And the idea was, look, we're going to place a 2.5 by 10 millimeter device. If antegrade flow looks really bad, we'll stop the dual antiplatelet therapy, and we'll use the thrombogenicity of the device, in this case, as a sacrifice tool. And I thought that that would actually be a more effective approach than trying to pack coils in this very unstable ruptured segment. And so, we're using a characteristic of the device, which is typically thought of as a liability to our advantage. But I also thought, if flow looks pretty good, antegrade, then, we will keep the patient on dual antiplatelets and kind of stay the course. So here are working projections here, and you can see the area of dissecting aneurysm in the oblique AP view here, as well as the lateral view here. And what we're going to do is we're going to flow divert out into this pre-Rolandic division, M4 back through M3. And so we'll end up jailing this prefrontal division, which I'm perfectly comfortable doing. So here I have a phenom plus in the in the cavernous segment. And we have a 027 catheter all the way out in the pre-Rolandic division. And this is just what it looked like to advance the device. I kept wondering if this was necessarily a good idea, but I really thought that it was the best option that we had in this case. And there's quite a bit of tension on the system going through this much tortuosity, but nevertheless, it actually seemed fairly reasonable. The catheter systems were fairly stable. And so I was feeling increasingly comfortable as I was advancing the tool into position and getting ready to deploy it. So here, we have a 15 millimeter lead wire here. So always a good moment to check and just sort of confirm that the sizing that we're looking at is reasonable. I knew my 2.5 millimeter diameter device would be quite constrained. And so I'd get more than 10 millimeter length out of it in this setting. So here we go. We're going to deploy the device. And, so this is the device deployed. And immediately we no longer see that sort of luminal irregularity. So the kind of aneurysmal component is immediately sort of, no longer pacifying, which gave me some comfort. Here's the device. You see that it's quite constrained. Again, we'd be doing cone beam CT imaging in our current protocol these days. And here's the device in that lateral oblique. And notice that this prefrontal division stays patent through the wall of the device. So fairly constrained. So the patient did very well. I actually brought the patient back later the same day just to see if the flow still looked, nicely antegrade, and it did. So again, we decided to keep the patient on dual antiplatelets. We brought the patient back 5 days later for an MRA and just looking for a flow-related signal inside the stent. And you see, it looks actually very nice. We have good flow-related signal in the center of the stent. So again, keeping the patient on dual antiplatelets. So the patient was discharged home, did beautifully. We brought the patient back 6 months later for follow-up, and this was actually the somewhat surprising angiogram that we obtained at 6-month follow-up. So I don't know if somebody wants to unmute themselves and say what seems to have happened here in the ensuing 6 months that is quite surprising. Notice that this JL branch stays patent as expected. We'll take a look at this here. Fade the stent away. And this sort of shape of this segment of artery is actually real. I'll show you what this looks like angiographically in just a moment.
So I was wondering, when you initially deployed the device, you actually saw that the device expanded to a size that seemed larger than the artery. And I was wondering what you were thinking about that at the time.
Yeah, maybe just a hair. And these stents have some radial force, and there was some vasospasm. So maybe it opened things up just a little bit, and I think that that's fine. And some of that depends like how much load you give the device as you're deploying it. But remember, this mid segment here was sort of aneurysmal at the time, so it's sort of taking a little bit of the contour of some of that slightly more patulous segment, though. We're not seeing any of those little sort of lumps and bumps outside of the stent opacifying. But notice that we're really kind of constrained to about 8 millimeters here,
there, yeah.
0.8 millimeters here at the proximal end of the stent. And so I thought that was all fine. We're not seeing any of the aneurysmal sort of focally aneurysmal components opacifying. But as we return, the stent has really kind of expanded to nominal. It's expanded to basically 2.5 by 10 millimeter device, creating this segment of artery that's a little bit enlarged as compared to the rest of the circulation at this level. And this was a little bit of a surprise. If we kind of fade the digital subtraction here, notice that we have stent wall here. We've got this layer that's not opacifying that we presume is endothelium. And then we have this kind of barrel-shaped artery here. And I think that, a few things happened here. I mean, I was very surprised to see that the stent had expanded to nominal over time. I've never seen that before in any other setting. But I think that, the stent, this far distally, the stent has a certain radial force, and these are super thin, very elastic lamina this far distally in the arterial tree. And then on top of that, you have a segment that's sort of badly dissected. And so probably the integrity of the wall is somewhat compromised at this level as well. And somewhere between the two, the stent has enough radial force to continue expanding. And yet, it's not tearing through a vessel wall. There is no additional hemorrhage. The patient has been asymptomatic and is doing beautifully. It just sort of heals in a sort of slightly surprising and unusual way, where you have a segment of artery that's a little bit expanded. Nevertheless, when we look at an MRI on this patient and you look at the pre-Rolandic kind of territory here, where that larger division was going, the territory that we flow diverted into, notice that we don't have any encephalomalacia here. And so I think that is a kind of proof of principle for this approach in this case. And I also think that this case introduces the idea of using the thrombogenicity of the device to your advantage, which I think is always a smart way of approaching tools, to kind of master the tool, think about the tool and all of its characteristics, and then also be willing to think about the tool outside the box for different indications where you can leverage various characteristics to your advantage. I'll just share very briefly our protocol with respect to doing ruptured flow diversion. We've done about 50 of these cases. It's a series that is on my list to write up in the near future. So I like to load on ticagrelor or Brilinta. I do 90 at 4 a.m., 90 at 6 a.m. with 81 of aspirin, and then we start at 8 a.m., period, hard stop. So we don't do these cases on weekends. We'll only have one practitioner, and the person may get called away for a stroke. We start the case at 8 a.m., and then patient gets started on 60 BID starting that evening. So the patients are slightly supertherapeutic when we do the case. These patients are hypercoagulable, and they are focally hypercoagulable right where the device is going in. So don't mind them being slightly supertherapeutic, but then we want them to come down to a slightly more reasonably therapeutic range over the next few days. Now, there are many ways of loading antiplatelets. What's much more challenging is actually taking patients off their antiplatelets for procedures, EVDs, trachs, pegs, and I don't see any protocol for this supporting this in the literature. First, remember that the tool gets much less thrombogenic over the first 2 weeks. So you need to push these procedures as long as you possibly can and try to get to that 2-week mark where the device has decreased in thrombogenicity dramatically. So this protocol has worked extremely well for us, and I'll show you the sort of underlying fundamental pharmacokinetics that we use to derive this protocol. But essentially, we skip an entire day of Brilinta with give the 81 of aspirin in the morning, give 81 of aspirin the next morning. We do all of our procedures between 10 and noon. If they had anything done in the head, they get a head CT immediately post. 2 hours after the final procedure, they get 60 of Brilinta, and they get their evening dose that night. Again, we've never had a bleeding or a thromboembolic event using this protocol. It's worked extremely well. I've reviewed every study in this literature. I don't find any protocol for doing this. If you look at a meta-analysis in this literature, there's about a 20% risk of hemorrhage during procedures in patients who have had ruptured flow diversion cases, so not insignificant. If you look at the onset of ticagrelor, it's actually quite a bit faster than clopidogrel, where you get to about 80% of its efficacy over about 1 hour and 100% over 2 hours. So just remember, it's about 2 hours to full onset, whereas it takes about 8 hours for the clopidogrel. And then, of course, you have non-responders and you have hyper-responders. If you look at the offset, even more importantly, don't look at the absolute values here because these were all medium clopidogrel responders. These are patients who are given a load and then given nothing more. But notice that the ticagrelor, not surprisingly, it's a BID drug. It has about a 9-hour excretion half-life, comes down over the first 36 hours to about 60% or so of its original maximum efficacy. And that's what we're looking for as a sweet spot, about that 20 to 30% inhibition at the time that you reach that 36-hour point, which tends to be the sweet spot for both not having bleeding or thromboembolic events. Okay. So switching gears a little bit to another type of distal case. And this is the sort of idea of doing some sort of endosaccular approach in anticipation of flow diversion. A lot of these pericallosal aneurysms tend to be wide neck, irregular, a neck that's sort of sharing a bifurcation. And so these are challenging cases to cure from the perspective of endovascular approach only, endosaccular approach only. And I would like to actually quote Dr. McDougall from the BRAT trial when he wrote that in the patients who were crossed over from coiling to clipping, that most patients, however, crossed over to clipping because they had anatomic features judged to render endovascular coil embolization impossible or disproportionately difficult compared with the clipping procedure. Although many aneurysms could be partially occluded with coils, the value of doing so is poorly defined, and our philosophy was that long-term durability was desired. This concern about long-term durability was considered particularly important for young patients. I completely 100% agree with everything in this commentary. However, I think that in the era of flow diversion, there's another option other than switching the patient over to open surgery, which is to marry the safety of coiling and some sort of temporizing effect with the ultimate durability of flow diversion. And so, some people call it plug and pipe, whatever you want to call it philosophically. For those of you as you get into your practice, knowing that you have a flow diverter in your back pocket should really give you a tremendous sense of comfort in doing these cases and trying to temporize an aneurysm, knowing that you will then come back and cure the lesion later. So here's a 59-year-old healthy patient with subarachnoid hemorrhage. Has this sort of wide neck, kind of ugly pericallosal aneurysm, right? The pericallosal and callosal marginal junction here. So this is something that we coiled, just went up primarily coiled, no balloon or anything. I try not to use balloons if I don't need to. Typically speaking, if you're a little bit patient, you can kind of form a nice basket over the neck of an aneurysm, even a wide neck aneurysm like this one. Patient cruised through the vasospasm period, did beautifully. Now, a lot of people might be satisfied with this result, but what I would argue actually is that this aneurysm is a segmental disease of an artery, that the parent artery here is actually a diseased vessel. And so even if you were to make this look like a perfect cylinder, either with clipping or with some sort of endosaccular approach, that the apparent artery along this segment is actually aneurysmal. And so I would say that this needs a flow diverter to cure this lesion. Anything else is temporizing. Now, some of these temporizing measures may be enough, but I think philosophically in the modern era, our goal should always be to cure an aneurysm. So we brought this patient back for a flow diversion and placed one flow diverter here. Now, in this case, I added a little extra load over the neck of this just to give ourselves a little more coverage. Change the cell structure of the flow diverter to make it more sort of diamond-like and give myself extra coverage with a more neutral deployment as the pericallosal artery came out right here. Now, the pericallosal artery, remember, has collateral support too, because of the anterior pericallosal and has posterior pericallosal support as well. So it's not something that I'm concerned about gelling. I know we hear a lot of concern about, gelling any sort of PL artery, but in the vast majority of cases, the patients have, there's a low resistance circulation, and then on top of that, the patients have PL collateral. That can often pick up the supply. So a patient comes back 6 months later. This is a super dyna using a fused dyna CT with a 4-second dual volume acquisition. And notice you can see where the cells are extra loaded over the neck of the original aneurysm over this aneurysmal segment of artery. Notice that the pericallosal artery is smaller here, but the patient is asymptomatic because this territory has been picked up by the posterior pericallosal. This lesion is now cured, and send the patient home. The patient did beautifully. So this was a 51-year-old male who presented with spontaneous subarachnoid hemorrhage. Go through the non-contrast head CT, a tremendous amount of subarachnoid blood. As we get a little higher here, notice in the interhemispheric fissure, you have a sort of a round structure here that's slightly different attenuation than the rest of the hematoma. We have subarachnoid, hemorrhage, interventricular, subdural. So probably, fairly elevated ICP, probably best not to do a craniotomy in this patient. This was actually a case that my partner coiled. Now, it looks like you can fairly clearly identify the pseudoaneurysmal focus on this A2, A3 segment aneurysm. So this is something that in our practice at this point, we'll just sort of do whatever we can to temporize this. And so my partner coiled this, no longer opacifying the pseudoaneurysmal segment. And that's really, the only goal in this case is really just to kind of temporize this for some duration. We returned, brought the patient back 6 months later. And notice even on a fairly straight segment, this is our first angiographic frame. Really, we have the first jet go straight into the aneurysm. You get sort of swirling around the aneurysm here and then back out. This is definitely not a remnant that I would want to leave this patient with. I don't think that this is durable, in any way whatsoever for a patient in their 50s. But nevertheless, a case that will bring the patient back, use 2 flow diverters here. And now in our first angiographic frame after placing the devices, notice that, we're seeing all the way out to, A3, A4. And then the flow through the wall of these devices tends to be at 90 degrees. So all of a sudden we get this sort of this sort of 90-degree sort of blunted flow into the aneurysm, as well as stasis within the aneurysm. And 6 months later, this is cured. So here's, in a similar vein, a 47-year-old with subarachnoid hemorrhage. And, here's a case where a neck really kind of spanned. This is actually an azygous configuration anterior cerebral artery. So these are bilateral pericallosal arteries. And this is a tricky aneurysm because the neck is actually fairly wide. It spans this bifurcation. And then the rupture point actually appears to be right at the base here. I think this is challenging both for open as well as, endovascular approach. But in this case, what I thought I could do is sort of tip a web kind of sideways in this. I knew I'd leave a large cleft on this side of the aneurysm. I didn't really care because I thought that I could kind of seal over the over this pseudoaneurysmal focus, which I was convinced was what I was really trying to temporize. So if we're looking, this is a coronal dyna CT here. So we're getting into the aneurysm here, and here's this cleft on the left side of this. We're getting into the pseudoaneurysmal focus here, and here's my web. And I'm very nicely seated over this, and so I feel very comfortable with this. Patient did beautifully, cruised through the vasospasm period. And we bring the patient back for follow-up. This is super dyna as well. And you can see we're certainly no longer seeing this half of the aneurysm. We're certainly no longer seeing that pseudoaneurysmal focus, but nevertheless, we leave the patient with a fairly large remnant. Now, in this case, I had originally planned to flow divert out into this slightly straighter pericallosal artery. However, when I brought the patient back, these 2 pericallosal arteries, if you'll remember on the original angiographic series, were about the same size. The reason why they are not the same size is because the shoulder of my web device is kind of impinging on the outflow here and causing a little bit of stenosis. So that changed my approach because I thought I don't really want to double gel this artery. And so I decided, instead I'm going to come up this pericallosal. I'm going to flow divert here and, load up the device so that I kind of create a little more radial force, push the shoulder of the web away, and kind of take a different approach to what I had originally planned. Okay, so here we go. We have our Phenom Plus out in this azygous anterior cerebral artery. We've got a 24 guide wire here making the turn. And 24 guide wires have made cases like this just vastly, vastly easier. Because what used to happen in cases like this when you're using a 14 wire and a 27 catheter is that as you come around this turn, you're going to get stuck because of ledge effect on this distal neck. And getting through that segment is not necessarily that easy. We used to use typically a buddy wire with an 010 wire next to an 014 wire. But it's very hard to control each of the wires, and the two need to line up properly within the catheter in order to eliminate the ledge effect. Not terribly easy. And that access has become really actually quite straightforward. So that's the wire access. And then notice that there's no ledge effect whatsoever. And so I can easily advance this system. Now, this not only makes my life easier, but as you'll see in just a moment, we have a microcatheter here in an artery that's close to the same size as the microcatheter. And so you might wonder, are we causing quite a bit of vasospasm here? Are we occlusive here? And in doing sort of gentle catheterizations with the proper wires for the proper tools, notice that here, as we puff a little bit of contrast here, I'm going to come out of this. I ended up in this little branch of this bifurcation. As we're puffing contrast here, notice that we have excellent runoff. We're barely occlusive at all. And so here you have, a microcatheter that's almost the same size as the artery that you're in. But having done the catheterization with the proper tool, it's actually, you have actually very nice runoff. And I don't use any prophylactic verapamil or anything like that. This is just all, just went straight up with the tools. In fact, I don't even give any heparin until I've crossed the lesion. You notice that we have a little bit of shift of the roadmap. In this case, I want to land the device right here. So it's a fairly short landing zone. As the roadmap shifts, however, I have as a guide these little radiopaque, poles of my web to use as guidance. And so if I don't have to, I won't cover this anterior frontal division of the anterior cerebral artery. And so landing on this little segment is really ideal. So here's a super dyna after my device goes in. I feel happy. I think that I've hit my my landing zone here. Notice that I've pushed the shoulder of the web away. And one other way of representing the relationship of the two tools is to look at a MIP, which on these dyna CTs can be really beautiful. And notice that you can see the interface of my device, my flow diverter, and the web. And as I've loaded the tool up, you can see that I'm really successfully opening this tool to its near full diameter and kind of pushing the device away. So this is what it looks like angiographically with the device immediately post placement, which I'm quite happy with. And if we compare these two, there are a number of things that are happening. One of them, actually, in terms of a flow diverting effect here, is not just the blood flow going through the wall of the stent, but it's also that I've actually straightened out a fairly tight turn in the vessel wall. Now, this happens in internal carotid arteries as well when you put these devices in more proximally, but it happens to a greater extent farther out in the PL arterial tree, where the arteries are sort of less anchored and they're smaller. And this actually gives you quite a bit of flow diversion, because in the previous anatomic configuration, there's a pretty direct jet of inflow into this remnant. And simply by straightening out this curvature in the artery, you actually give yourself a much more favorable configuration with respect to blood flow into the aneurysm, and it becomes a little bit less of a sort of terminal physiology and a little bit more of a kind of sidewall physiology, which I think is beneficial in and of itself. Patient did beautifully and went home the next morning. Excuse me. And came back 6 months later. This is what it looked like angiographically. We'll look at a super dyna here. And notice that the aneurysm, we can see just a tiny little residual aneurysm. It's probably decreased by about 95% by volume over 6 months, which I'm very happy with. Notice that also this pericallosal artery has now been restored to its full size. This one is now jailed. The patient is asymptomatic and doing beautifully. If we take a look here, things are heading very rapidly in the right direction. I think that the 5-year PUFS data gives us license to do no more in cases like this, in that we went from around 80% cure at 6 months to 95% cure at 5 years, and no aneurysm went in the wrong direction. So once an aneurysm has started shrinking by volume by about 95%, I think we're comfortable to continue watching it at this point. So, in some cases, we have more distal anatomy just created by the arrangement or configuration of the circle of Willis. This was a 65-year-old patient who had a new onset right third nerve palsy, complete right third nerve palsy, who was found to have this, sort of pre-mesencephalic lesion here, which turned out to be a largely thrombosed aneurysm. Now, in this case, this turned out to be a little bit farther out in the arterial tree simply because this patient had no, visible P1 segments of a posterior cerebral artery. So this turns out to be a PCOM case and a little bit more distally PCOM. If you look at the slices from the CTA, you can see that there's the lesion here, start to see opacification here. And now we get up to the posterior cerebral artery sort of, P1, P2 segment. So, this is the really dominant supply from PCOM. Now, cases like this go really beautifully for a number of reasons. One of them is that this is kind of a wide neck lesion. It's sort of difficult to address in any other manner. But another one is that this is like a real sidewall kind of physiology. And so as the flow diverter goes in, you can see that there's a little bit of an angle here. You're going to straighten that out. And so you're going to have very little jet of inflow directly into this lesion. So as you place your flow diverter there, these are the kinds of cases where the aneurysm thromboses immediately in a way that does not signify that you have a thromboembolic issue. Sometimes the one that happens in ICA aneurysms, paraophthalmic aneurysms, you should be quite careful because they shouldn't disappear that quickly. These are the kind of aneurysms where you have a true like sidewall physiology, and you're making it even more of a sidewall by straightening out this slight curvature in the vessel. Aneurysm often disappears immediately, and that's something that you can expect. So we put our single device in here, really see very little aneurysm opacification right out of the gate. Within 6 months, the mass lesion disappeared. The patient came back in, third nerve palsy had completely resolved. And so, you almost don't need to do the angiography at that point. But nevertheless, just for the standpoint of knowing that, you don't have a severe stenosis or even an occlusion, certainly worth doing. And so, here we have little collicular division coming off of the P1 segment. You've got perforators here, but something that we're very comfortable doing in terms of flow diverting in a segment like this, something that is made a little bit more distal by the absence of a P1 segment. So we'll switch gears a little bit to discuss the general concept of, well, two concepts really. One of them is flow diverting proximally to treat distally, and the second one is rearranging the circle of Willis. So here's a challenging aneurysm. We have a 50-year-old male who was sent to us for, we've discovered an aneurysm on workup for headaches, and was found to have this kind of fusiform, ugly A1 segment. Notice also that the origin of the A1 is actually aneurysmal as well. And so the question is what to do for this. People, talk about doing bypasses and things, but I think you have a really beautiful solution. Now, the solution involves flow diverting proximally to treat distally, which I think is a really important thing to keep in the back of your mind as part of the therapeutic arsenal. And the reason is that flow diversion conventionally works by sort of advancing a construct through a fusiform segment, and then having the stents endothelialize, excluding the fusiform segment from circulation. But in a case like this, I think you're going to be very challenged to do that because this origin here is over 5 millimeters in size. You're going to jail the MCA, and you're also going to it's just going to be very, very difficult to tack against this origin, even if it was less than 5 millimeters in size, because of the way that you're going to be constrained by the carotid terminus coming through here. And so I think a much more elegant solution is to think about the idea of flow diverting proximally to treat distally, which is to flow divert from the ICA to the MCA. In this case, I'll use 2 stents coverage, one from the M1 across the neck, the other from the distal neck into the ICA. So basically 2 stent coverage over the neck, 1 stent coverage everywhere else. And we have a few different options at that point. One of them is that this endothelializes and the aneurysm goes away. Another is that this doesn't endothelialize, the aneurysm stays patent. We can come back, we could add a flow diverter in the pre-existing construct. I think that's a nice option. And then another one is that this largely endothelializes, but the aneurysm stays patent. And at that point, we could have come up through the A1 through ACOM back into this, and we could always pack coils in this against the flow diverter. So I think we have quite a few options. I don't think that we have to tip things in that direction out of the gate, however. I think we can start by really beautifully constraining flow into this antegrade, flow diverting proximally to treat distally, and forcing a rearrangement of the circle of Willis. So this is just to show we have a large ACOM. It's a fenestrated ACOM, and nevertheless, it's large. Okay, so here we go, looking at the sizes using our aneurysm analysis tool. So we use two tools. So on our first angiographic frame here, before we place the flow diverter, as is so often the case, we have this jet of flow that's hitting the back wall of the aneurysm, and then you get this sort of swirling flow. You see these two sort of tendrils of contrast. You get this sort of swirling flow in the aneurysm. We fill it very quickly. We have washout here. Okay, so a fairly straightforward technical case, I think. It's all access is fairly straightforward. These are fairly straight segments to deploy flow diverters on. Here's our first device. Here's our second device. So you notice that we have this two-stent coverage. We're changing the diameters to change the shapes of the cells over this two-stent segment over the neck of the aneurysm. I think that we're nicely seated both cases. Now, here's our first angiographic frame post-stent placement. And as we said previously, we get this blunted jet, and it also goes through the stent wall at 90 degrees. So we're taking advantage of this kind of flow effect, taking stress off of the distal wall, the far wall of the aneurysm. And then we have this kind of slow flow. We keep this patient on a heparin drip over the first 24 hours, simply because we have this really slow flow in the aneurysm that could thrombose and could create thromboembolic issues in the ACA. The patient beautifully went home the next morning, returned for 6 months under general anesthesia in case we had to do additional procedures. So we notice that things look nice here, right? We're no longer pacifying any of that. The stents have completely endothelialized. But we still need to shoot the left ICA simply because we need to see, is this aneurysm filling antegrade from the through ACOM and retrograde from the A1. And what we see is actually something really beautiful, which we see in a lot of these cases, which is ACOM has enlarged a little bit. We have beautiful flow into the right ACA. And then look at the A1 on the right side here. It actually tapers down right to the size of this lenticular striate artery, and just like has become the perfect size for the supply that it needs, which is just to support this medial lenticular striate. And so, something that you couldn't possibly do on your own. You can't possibly do something this elegant. You can't possibly, there are no tools that we have that will force the vasculature to do exactly what it needs to do in this sort of beautiful, elegant, perfect way. However, if you kind of think about flow diversion slightly different conceptually, and you're thinking about it in terms of forcing a rearrangement of the circle of Willis, the system will rearrange anatomically to support the flow that it needs in a way that's in this beautifully elegant way, and in a way that you can't possibly sort of force it to do. So I think it's a really elegant solution, and one to keep in the back of your mind. So in terms of rearranging collateral circle, here's another case. This is also in a smaller artery, but a slightly more proximal smaller artery. This is a healthy 53-year-old who was found to have a basilar fenestration aneurysm. The aneurysm was actually slightly bigger than this. This was, again, I would have done this with cone beam CT imaging these days. This was a subtracted image, and so we're subtracting out some contrast that's sitting in this aneurysm. Nevertheless, here we have this basilar fenestration aneurysm. Now, in some cases, you can just sacrifice the entire non-dominant limb of the fenestration. However, in this case, we didn't have that option because you have this fairly large dominant medullary perforator that's coming off of the non-dominant limb. So how to do this, how to give a 53-year-old a cure of this lesion. So what I decided to do was actually to flow divert from the right side, land the device just in this very small, about, maybe around 1 millimeter landing zone distally, and flow divert across the origin of this non-dominant limb of the fenestration. I then have the option later, once again, if the aneurysm stays patent, I can always come back through the left vert, down through the distal part of the limb of the fenestration, and get into the aneurysm this way and put coils in there. The flow will certainly have been blunted. And so I think that endosaccular approaches, when they're behind a flow diverter, are actually much more effective. You're much less likely to have things like compaction when you have already blunted the flow, the antegrade flow with a flow diverter. And so I think that this represents a nice option. Now, how to pull this off technically? What I did was I catheterized the left vert with just a diagnostic catheter, so I have a way of shooting images here, and then came up the right vert to do the flow diversion case. But it's a fairly small vert. I was using a Phenom Plus, so I don't really have the option of doing arteriography from the right vert, but nevertheless, I can from the left. And so this was actually my system as it goes through the stern. Now notice that, we have a curvature of the vessel here. My system has decided to stay completely 100% linear. And so it's going to be a little hard to land right on this in this position here. But, what you can do is start to deploy a little bit of device here. as I've done. I think I've actually hit my landing zone. I'm shooting from the left. I have a really nice way of looking at this. Really important to take time to get an excellent AP working projection where this segment is really opened up, so it's not the slightest bit foreshortened because you have a very short landing zone. So you start to open up the tool, start to deploy a little bit more of it, and I'm quite happy. I think I've nailed my landing zone here on my first try. But I don't mind recapturing and doing this a few times. You have a great way of visualizing this. So I deployed the device under quite a bit of load here, and I think that I've nailed my landing zone. Again, this would be a Dynasty T today. This was a classic dual volume, so forgive the image quality. But nevertheless, I think I've hit my landing zone here. I'm right over the origin of the non-dominant limb of this fenestration. And patient did beautifully, went home the next morning. And when the patient returns for follow-up here, again, brought the patient back under general anesthesia in case I needed to do more with this lesion. Notice that we're no longer opacifying this limb of this fenestration antegrade, but look what happens. The limbs of this non-dominant limb of the fenestration stays patent, arising more distally from the basilar artery, and has is decreased in size to the perfect size for runoff into that dominant perforator that we were trying to keep open from the beginning of the case. And so we've rearranged another collateral circle. In this case, it was not the circle of Willis. It was a collateral circle related to a basilar fenestration. But nevertheless, given the system constraint on one side, to sort of tip it in the direction of healing and helping it to rearrange in this sort of beautiful, elegant way, such that it becomes the perfect size for the runoff that it needs, and everything stays patent. And the patient did beautifully here. So, in this case, in the past two cases, we've been rearranging collateral circles, but we have another option, which is to take advantage of collateral. And collateral exists in many places where you don't necessarily study it and haven't necessarily thought that it exists. So here's another proximal, nevertheless small artery atypical case. 72-year-old on anticoagulation for AFib. So we kept her on anticoagulation and added ticagrelor to the anticoagulation regimen, otherwise healthy and active. So found to have this pica aneurysm. And as these pica aneurysms often are, they often don't have a neck on the vertebral artery. Oftentimes the neck is on the first segment of the posterior inferior cerebellar artery. And so, in addition, the origin of the pica is actually aneurysmal. It is about 40% larger than the artery as it continues. So, how to reconstruct this? You could try something saccular, sort of above and below in this kind of kidney bean shaped aneurysm, but it's going to be challenging. It's going to be difficult to keep this conduit patent. And then what are you left with? For the risk that you take, what are you left with in terms of the residual aneurysm and the risk of the residual aneurysm and the point that was made so beautifully in the write-up of the Bratt trial? And so I think a really nice solution here is actually just to flow divert in the vertebral artery and to do it in a staged manner. And, I'm not sure that the cure rate on the first deployment is necessarily very high, but I think it's a very technically easy case. And so, when you look at a risk-benefit ratio, I think the risk of these cases gets so low that even if the benefit isn't perfect after one device, and I think it does actually go up with each additional device as you stage, I think that ratio still looks very favorable compared to almost any other way of addressing this lesion, particularly in a patient on AFib. And if you're doing an open procedure, you're gonna have to take her off for anticoagulation, and now all of a sudden you're at risk for having a major stroke. Okay, so put one device in over the neck of this. And as we were saying before, there is a flow effect with these tools where the jet of contrast is going to go through the wall of the stent at 90 degrees. And you can see it sort of bypasses the aneurysm. So I was very excited, and I was sort of like, maybe just based on flow effect alone, one device will cure this thing. We're sort of bypassing the aneurysm and seeing more of the pica on our first frame. We sort of, slowly filling the aneurysm. Brought the patient back under GA 6 months later, and I was a little disappointed. The aneurysm really hasn't changed in size. The neck has gotten smaller here. You've got more of a, blunted jet into the aneurysm, but then, the flow sort of slowly enters this, swirls around, fills the entire aneurysm. So I just staged this. I added another device. Now, these are very straightforward cases because you can't get into the aneurysm if you wanted to. And furthermore, for all of the shifting of the roadmap and things that occur with these cases, you have the first device that's going to be your guide. So you can almost deploy these on a native X-ray image, native fluoroscopic image. So very straightforward case. I put in a device with a slightly larger diameter just to take advantage of constraining the cells and having different cell shape of the two devices to increase coverage. And we bring the patient back. Patient's asymptomatic, does beautifully, goes home the next day. We bring the patient back, aneurysm is gone, and the pica appears to be gone too. However, the pica isn't really gone. This is the lateral spinal artery here. And I just want to show you this from the first case to the CURE angiographic series. So if we look here, we have this lateral spinal artery here, and the lateral spinal is closely related to pica embryologically. And if you'll notice, we have this loop of pica here that I'm pointing out in blue, and this is actually opacifying. So the pica actually is opacifying antegrade, just not opacifying antegrade from the origin. But you have small collateral that has picked up all of that supply. Patient is asymptomatic. The lateral spinal artery has picked up the supply to the rest of the pica. And here's the patient is completely asymptomatic. And so there's pedal collateral potential that goes far above and beyond just the classic pedal collaterals that we think of as ACA, MCA, PCA, MCA, the things that we study in stroke physiology and that we think of as creating a therapeutic window for thrombectomy in cases such as this. And you can take advantage of these in a staged procedure for curing a complex sort of wide neck aneurysm. We'll go over one other case here, and then I'll wind down. Another ruptured case in a similar location that makes more of a point about the sort of elegance of this pedal collateral potential in areas that we don't necessarily consider, and how it can be sort of utilized or leveraged in the case of treating atypical flow diversion cases in either distal small vessels or more proximal small vessel disease. So this is a 45-year-old, actually there's a local physician with subarachnoid hemorrhage. Patient is actually an ER physician who came in, and the patient actually presented with left hemiplegia. So a tremendous amount of premedullary hemorrhage here, intraventricular, a lot of subarachnoid blood in this case. So patient turned out to have this ruptured dissecting vertebral pseudoaneurysm. And if you'll notice, it's right over the pica segment. And not only do you have pica here, but you also have this dominant medullary perforator coming off just a little bit distally. So not something that we can sacrifice. The anterior spinal artery comes off as well here. This is not something that I'm as worried about. Overwhelmingly, the dominant supply of the anterior spinal artery in the cervical axis is from the artery of cervical enlargement. So we don't typically worry too much about plugging the anterior spinal artery or constraining flow into the anterior spinal artery as it arises from the distal vert. But nevertheless, I definitely worry about the combination of pica and this dominant medullary perforator here, which you'd like to spare here. Looking at the 3Ds, you can see medullary perforator, pica, anterior spinal artery. So this is something that we'll flow divert using that same protocol that we used previously, both for loading and unloading. And we tried to use at least 2 devices in these ruptured cases, even in smaller vessels. If we can, if it's even remotely feasible or reasonable. And the reason is that these are not entirely protected until the device endothelializes. So constraining flow as much as possible into these unstable aneurysms is something that we philosophically believe in. And so in this case, I'm going to take the first device, kind of leave it floating over the neck, and I need to give myself a few millimeters with the second device so that it has enough room to open and tack against the origin of the posterior inferior cerebellar artery, just to make sure that we don't leave that outside of our stent and in the same pouch as the aneurysm, because it can pull flow through the walls of the stent and keep the aneurysm patent. Okay, so choose a good working projection here. Here's our stent construct, and if you'll notice here, we take a closer look. That's device number 1. That's device number 2. You can see we gave ourselves a few millimeters to come out of the first device, open up to the full size of the diameter of this artery and tack against the posterior inferior cerebellar artery. So now this patient was actually pegged and trached. Patient was sent to rehab. Both the peg and the trach were reversed. And the patient actually made a full motor recovery and is back to being a fully functional physician. So it's really a wonderful story and a wonderful recovery. However, what I want to point out here is something very unique that occurred, as we can see when we came back, which is that this dominant medullary perforator, which, if you'll recall, originally arose from the vertebral artery here. When we come back, having constrained this twice, so this had 2 stent coverage over this segment here, that same segment now arises from the origin of the pica, perhaps as part of a lateral spinal kind of network here, arcade along the lateral medulla going down into the cervical spine. You have this collateral potential where you may not know it exists. And so you might say, well, I really don't want to cover this with 2 stents. I'm not sure that's safe. And yet here you have collateral potential in a place that you didn't even realize was a possibility. And think that, cases like this amaze me. I sort of marvel at them. I think that it's be a wonderful thing. I know, you have a high power program. I know you have extremely, brilliant trainees in your program. And this would be something incredible to study, to study the plasticity associated with these systems, why some people appear to have more plastic peel collateral potential than others, and then also to study some of these smaller systems where we don't necessarily understand or think about collateral potential, but nevertheless it exists. And you can leverage in cases like this where you're not as worried about using multi-stent coverage over a small important perforator in the brainstem because of the potential existence of collateral such as these. So I'll wind down there. I hope that this opened some doors. I hope that this made you think about certain types of challenging lesions in a new way. I think that flow diversion is an effective tool for a variety of distal aneurysms as well as proximal smaller vessel atypical aneurysms. I think understanding your tools and leveraging their characteristics, even characteristics that might seem ordinarily like liabilities, is opens doors in the way that you think about approaches to disease. I think that you have this concept of flow diverting proximally to treat distally. You have a concept of rearranging the circle of Willis as well as rearranging other arterial collateral circles. I think that there's this concept of collateral potential both with classic PO collaterals as well as other collateral systems in smaller arteries that we don't often think of or discuss or even necessarily understand that well. And I hope that this was stimulating and provocative to some extent, and you enjoyed this. And I'd be happy to take some questions. So thank you.
Yes, good morning. That was a great talk, and thanks for showing all the plethora of cases. One of the fellows, I'm going to be fielding questions from the chat box, and one question is, what particular features of the aneurysm would inform flow diversion versus stent-assisted coiling?
So that's a great question. And I certainly come with a bit of a bias. And I do think that there's a role for stent-assisted coiling, though I think in the vast majority of cases these days, from my perspective, I think flow diversion is a better option, even when it comes to bifurcation aneurysms, because I think that, for the cases that get receive stent-assisted coiling, they're oftentimes at, a sort of bifurcation where you have a fairly direct sort of inflow into the aneurysm, and you have a kind of bifurcation. You're trying to provide a better prop for something endosaccular, typically coils. And I think that oftentimes those are specifically the type of physiology for aneurysms where coils fail. And I think that when coils fail, it's not necessarily that that like you didn't pack the aneurysm tightly enough or something. I think a lot of time it's because the paradigm of coils has failed. And I'm sure you all have seen this, and this was actually a little bit of a surprise to me, being someone who comes from the endovascular only side, which is that when you go in to clip a failed, endosaccular coiled aneurysm, the coils oftentimes, at least some of them, are in the subarachnoid space. So, I'd always picture them as sort of sitting at the top of a pouch, atop a blind ending pouch, but they're actually in the subarachnoid space. And so that's telling you that this is much more complex sort of biology and physiology than we necessarily give it credit for, that, that there's this kind of pressurized flow coming in from below, that the tissue of the aneurysm wall is constantly sort of, breaking down and growing and whatever is happening. And these things are actually migrating out of the aneurysm. And so to me, that says that, or the kind of treatment philosophy that I derive from that understanding is to say that what is needed more often than not is to substantially blunt that jet of inflow. And I think the best way to do that is with a flow diverter. Now you have to pick a side, I don't find that to be so daunting typically. I think that overwhelmingly, patients tolerate jailing an artery, even like a major PL artery, particularly if you do it in a little bit of a staged fashion, kind of slowly constraining things. You give the system time to compensate. I'm not saying that the risk is zero. I just think that the risk is much lower than the degree of concern that I typically hear from groups that don't do all that much flow diversion. And I also think that for the most part, once you do stent-assisted coiling, whether you do like a Y construct or something, that it can become very difficult to flow divert later. You know, what Kim has started calling endoluminal debris. You have to kind of fight your way through the stents. It's hard to get them to seat. You can go through the wall of the stent and back out, and all of a sudden the device becomes very constrained, and it's hard to tell why. And so I think that there is, you know, sort of elegance or beauty in simplicity. And a lot of times that just means that you just kind of pick either a dominant trunk, or you pick a trunk that you think will, you know, best cover the neck, or create a 90-degree jet of outflow that sort of bypasses the aneurysm. Whatever sort of flow or direct neo-intimal kind of approach that you're using to address the aneurysm, overwhelmingly in the vast, vast, vast majority of the cases, to me, that means that a flow diverter is probably a better choice. And I think the cases are fairly technically easy. You don't risk, for the most part, or very minimal risk of rupturing the aneurysm as you're sort of jailed and have difficult access. I hear a lot, you know, well, you know, you don't have access to the aneurysm later, you know, if you do it this way. And so you're sort of locked into this treatment paradigm. And, you know, I don't entirely disagree, except that I think that you do have the option always to add another flow diverter. And I think that's actually a powerful option. And for all of the embolization that we do in the peel circulation, I think that the single lowest risk thing that we do is putting a flow diverter inside of a pre-existing flow diverter that was implanted months earlier. Because the access is extremely straightforward. The shifting roadmap makes things very easy. As we said before, you can basically do the deployment under a, you know, a live X-ray. You don't even really necessarily need a roadmap. You can't get into the aneurysm if you wanted to. And so those future cases are actually very straightforward. Conversely, in the argument that you need to sort of fight your way back into the aneurysm, I think you can, in a lot of cases, I've seen, you know, you get back into the aneurysm eventually, but in a place that you weren't intending to get back into. There's a pouch in one place. You can't fight your way back through the stent and interstices to get to that spot. And so people sort of settle. They're like, oh, well, you know, yeah, I couldn't get to that spot, but I could get to this spot. So I just added some coils here, and yeah, like we sort of bounced some coils off this area back, and we got like a little bit of packing in the part that we wanted to. But it's very, very hard. I think deceptively hard to get back into the aneurysm in the exact spot that you want to. And so I sort of take all of those together and say, you know, I think in the vast, vast majority of cases, flow diversion is a better option. I'll add that, you know, in terms of getting back into the aneurysm, I have a whole series of cases like this. You know, if you do something like a basilar tip aneurysm, and you know, go from the basilar artery into one of the two posterior cerebral arteries, what you'll find is that the jailed side, typically, overwhelmingly, the posterior communicating artery actually becomes larger. And so for the argument that you can't get back into the aneurysm, actually, a lot of times you can. You can't go through the wall of the flow diverter directly antegrade, but I have a whole series of cases where I've gone up, you know, through the ICA, through the posterior communicating artery, back through the P1, and coiled off remnants to cure, actually. Because you can get a very nice pack against you're packing against the flow diverter. So you have something really nice to pack against that you don't really have to worry about very much. And also the jet has already been blunted by the flow diverter. And so I think that those coils are more effective than they would be de novo. And so I guess I would say in the vast, vast majority of cases, with some very rare exceptions, I think flow diverters are a better option.
Yes, thanks. Dr. Patel?
Hi, thanks, Daniel. I appreciate it. This is Akshul. I'm one of the attendings here, and I really appreciate your talk. I'm in your camp in terms of flow diversion. I will say that from the start, but I am a surgeon, and one of the things that, well, I have a couple of maybe difficult questions to ask, but you know, one of the things I realized when I was younger, like 15 years ago, people used to talk about after subarachnoid hemorrhage, dome protection, things like that. And what I've done in my practice is clip a difficult aneurysm and then flow divert in the same, you know, in that same, you know, hospitalization. So let's say I have a difficult anterocommunicating artery aneurysm. I clip it. It's not perfect, but I want to get the patient, you know, okay and off the table, protect the dome with the clip, and later treat the residual with a pipeline, or a flow diverter, I should say, flow diverter. And that's been very useful. So my question, I have a couple of questions for you. One, for the similar setting for ruptured aneurysms and doing flow diversion, is there any way to know if the patient's going to have good collaterals? Is there anything that you do to force better collaterals after the pipeline has gone in or flow divert has gone in? And then my last question to wrap it up is, you know, do you ever see, because we do a lot of flow diversion now, do you ever foresee a situation in a very straightforward case, sending patient home the same day?
In a very straightforward case, electively,
Elective,
sending the patient home the same day? Okay, so well, thank you for those awesome questions. Nice to meet you over Zoom. So I think that that's fantastic. We in Goodman Campbell we have three cranial and skull-based neurosurgeons who do only open work. We do only endovascular work, and we do have cases where we've done something similar. I think any form of temporization that you feel comfortable with, I think is great. I think we have fewer of those cases than the sort of endosaccular sort of temporization. I think partly because it just seems like the literature is supportive of endovascular approach, and so but you look, there are aneurysms that are just super challenging endovascularly, and I'm thrilled that we have awesome cranial and skull-based surgeons that are in our same practice, that we're very close friends and colleagues, and that we can rely on, and it's they will come out of the case and they'll say, hey, I don't feel comfortable with this. Let's we need to do something more. And then the question is just really how to time that. Whether to do it in the same stay. I always worry that with vasospasm and so forth, maybe the patient does fine clinically. Is there a little dot or two of infarct? I don't know. I worry about delayed parenchymal hemorrhage. So in as much as we can wait, we try to wait. But we have done them in the same hospitalization, both for clipping as well as for endovascular, endosaccular approach. We've done both of those. With respect to the collateral, I don't have a great way of predicting that at all, and it's a great question, and we don't really do anything to sort of push the collateral to open in any way. I wish I had some way of doing that. I mean, I think it's a fascinating thing. There seems to be fairly large variability from patient to patient with respect to the plasticity of these systems, and there's no question in my mind that impacts the efficacy of the tool, particularly if you're doing something like a little atypical, like basilar to P1 or something, and where like if a PCOM gets large enough that it sort of takes over the supply to the PCA, like the whole stent's going to endothelialize and you're going to actually cure the aneurysm. And if it doesn't, you're going to have sort of pull through the wall of the stent and maybe keeps a little bit of the base of the aneurysm patent. And we have plenty of examples of both of those. So I would love to be able to predict that. I would love to understand that better. It's always a wonderful surprise when patients are a little bit more plastic. To me, it's almost like peel collateral, where it's like, it's definitely better in younger patients than older patients, but in any age category, you're going to see quite a bit of variability. But I think it's a wonderful thing to study. I heavily suspect that there is a genetic component, and there's probably a sort of acquired or like disease histopathologic sort of component too, where patients who have more diseased arteries, smokers, diabetics, and so forth are maybe a little bit less plastic. But I think it just feels like there is a like different patients have a sort of de novo capacity towards plasticity that is quite different from one patient to another, and that that sort of that plasticity impacts the efficacy of our tools, and it'd be a wonderful thing to understand.
Thank you.
I can jump in, Cliff.
Yes,
Dan, that was beautiful presentation. I always enjoy so much seeing people who do beautiful work, beautiful images and just so thoughtfully analyzed, and it's really the hallmark of somebody who's really mastered the craft. So I really enjoyed that. And it's also fun to sort of see the convergent evolution of practices. The 024 wire out in not that long ago, it would have been kind of unimaginable to put an 024 wire out the A4. And now it's like, man, that's power steering. We're just going to town with it. So that's great to see. I wanted to ask a little bit just about different devices. Clearly, you and rightfully come from a school where it seemed like you were using a single device for, and obviously it was working well in all these instances. But you mentioned what seemed like an arbitrary number of 1.8 millimeters, although you said you do go smaller sometimes. But I'm wondering about if you ever use any other devices, even some of the intermediate flow diverters, the Elvis type stents that they're promoting as having flow diverting properties in some of the smaller vessels. I wonder if you just make some comments on that.
That's a great question, and a great point. Yeah, I don't So we actually have. We had a ruptured superior cerebellar artery dissecting pseudoaneurysm, and we used an Elvis as a tiny artery. We used an Elvis, and actually the patient did quite well clinically. When we brought the patient back, actually the aneurysm still seemed to be opacifying just a little bit, but this was 6 months later. It had not re-ruptured. So and most of the aneurysm had sort of gone away. I don't love the claim of sort of, yes, like we have flow diverting properties. I just don't think it seems more of a marketing piece than anything else. So in general, I try to stay away from that, because also I think that there is a tendency to, once you hear that, there's just this natural tendency to do what I would call splitting the baby. It's like, oh, we're at a bifurcation. Yeah, like we kind of need to blunt this thing. There's like a really kind of direct inflow sort of physiology. But maybe like we could use like maybe a little bit less, or there's like a little less jailing. I think that those cases I haven't seen gone well,
It is people with commitment issues.
That's that's exactly right. So I think it's better just to say, no, I really need a true flow diverter here. I'm not going to talk myself into splitting the baby because of some concern about jailing. We're just going to do what we think is right here. This jet needs to be blunted appropriately. And I'm not sure how well those claims have even been substantiated exactly. But no, there are a whole slew of smaller flow diverters. I don't have a lot of experience with them. I know, you have Silk, Baby Vista, and some others that go through smaller systems, that are smaller wire systems. I know Surpass has a tiny Surpass that's coming out as well. And look, it'll be very interesting to see how these work in smaller arteries. I think that some of the demand for smaller systems, I think, is probably at least slightly misguided in that there's a lot of demand for putting these devices through a smaller catheter, for example. Well, look, I mean, you can put an 027 catheter in some very small arteries. When you get to a certain size, yes, it gets quite difficult, and you get, too much straightening and these kinds of things. But for even a lot of these cases, like an 027 catheter is pretty much okay. But there is a flip side to putting these devices through smaller catheters, which is that, these devices are very stretched. The average pipeline is about 2.8 size, loaded as it will be deployed. And so, certainly, I certainly appreciate that, but for some of your trainees, like a lot of the deployment is getting the stretch out of the device, and that requires a lot of catheter stability. So there's a lot of pushing. And so, in moving to smaller microcatheters, you might make the deployment quite a bit more challenging. Something that I don't think people necessarily consider when they say, oh, I would like a smaller microcatheter. It's on like everybody's sort of short list of sort of wish list for doing these kinds of cases. And so, there is no free lunch. I think, if in building smaller microcatheter systems, they might make smaller microcatheters that are quite a bit more stiff. I don't know if that necessarily, accomplishes everything that people wanted with a smaller microcatheter. But no, certainly I sort of meant to comment on that. I think it's a great point. You have some smaller true flow diverters that are coming out, and I think that it'll open the door for some really small, like more distal pica aneurysms, even some of these aneurysms that end up in like the fourth ventricle and these kinds of things that are sort of wide neck. And I think that there will be some beautiful work that people can pull off that might be a little bit challenging with a system of this size.
All right, we've kept you quite a bit beyond what you graciously agreed to spend with us, so we really appreciate the time. It's a beautiful talk, lovely work, and most importantly, really thoughtfully analyzed. So really enjoyed it. Thanks so much for being here, and really great to meet you, and look forward to meeting you in person one day.
Awesome. Thank you. You as well. It's an honor to be here.